My name is Caleb Burruss. It is May 1st, 2023. Okay, so I have Gaucher disease. And once again, my name is Caleb Burruss. So before we get started talking about Gaucher disease, we first need to understand what is a lysosome and what is the disease category it falls under, lysosomal storage disease. So lysosomes are responsible for breaking down unwanted material or recycling certain material. So they're called the trash compactor. It can also do things with stuff outside, foreign materials outside of the cell. Lysosomal storage diseases are a group of diseases that, obviously in the name, have dysfunction within the lysosome. Specifically, usually it has to do with a buildup of substrates. This can be due to a lack of an enzyme, dysfunction of an enzyme, anything like that. Mutated enzymes can all lead to these. So normally within a lysosome, we have something called glucocerebrosidase, which is the GCase is what we call it for short. And this was something that is going to break down the glucosylceramide into glucose and ceramide. These two things are responsible for the cell membrane or forming parts of the cell membrane. So together as glucosylceramide, they help form the membrane, and then whenever a cell dies or needs to recycle parts of this membrane, it takes it to the lysosome where it breaks that down back into glucosylceramide to form more parts for the cell membrane. During Gaucher disease, we see that there is a deficiency in the glucocerebrosidase, so the GCase enzyme, which leads to the glucosylceramide not being broken down. And so as it's not broken down, it starts to get build up, and there's a huge accumulation within the cell. This generally occurs within macrophages, but it occurs in a lot of different cells that have to go through phagocytosis or breaking down things. And so when they get this accumulation, so these macrophages, we call these Gaucher cells. Now, this accumulation, what it does to the macrophages is it prevents them from performing phagocytosis. So here on the right, a study has shown that PMA, which is a good indicator of phagocytosis, those levels are diminished within those that have Gaucher disease. And so they're unable to do their job anymore. So they just keep more buildup and more buildup and more buildup. On top of that, here is a picture showing a normal cell and a Gaucher cell. We can see in the Gaucher cell that this buildup of the glucosylceramide forms a twisted and almost like spider-web looking network throughout the cell, and so that creates so that cell can no longer do its function. And you can see that it's much bigger too, right? It's swollen because we have that buildup of the substrate within. Okay, so what is mutated? Why does this happen? Well, due to mutation in the GBA1 gene located on chromosome 1. What makes this disease so complicated is the fact that it has so many different mutations. Over 250 have been found. Generally, though, these mutations are single base mutations. So what this means is that if you look down here at the bottom, we have normally what would happen is we'd have a C nucleotide or base in this region, and then a T is replaced there. A mutation occurs where a T is put in for the C, and we get this different amino acid that is produced, or different enzyme that's produced that's not functioning the way it's supposed to, or it can't produce that enzyme it needs to produce anymore. And so that's what kind of what a single base substitution does. It's also called a missense mutation, same thing. Inheritance. So this is an inherited disease. So it is an autosomal recessive disease. And so what that means is that you have to have both copies of the mutated gene in order to have the disease. And so we see here on the left side, if we have one parent that's a carrier, you're not going to be affected. If you have one parent that is affected, you still have a 0% chance of being affected, but you have a 100% chance to be a carrier. And then if both parents are affected, you have a 25% chance to have Gaucher disease. And then if both parents have Gaucher disease, you also will have Gaucher disease. Okay, so there's 3 different phenotypes. There's type 1, type 2, and type 3. So type 1 is the most common one out of all of them, around 90%. And what differentiates this from other types is the fact that there's no neurological damage. Okay, so that is something that is differentiated from type 2 and type 3. It also does not, it can sometimes, I shouldn't say it doesn't, but sometimes it does not appear until about 10 to 20 years. It can appear early on, you can see symptoms, but generally you're not going to see symptoms until they're above the age of 10. And so some of the symptoms that we see with type 1 is enlarged spleen, fatigue due to the large spleen, which impacts the function of the spleen with white blood cells, red blood cell counts. enlarged liver, some tumors formed by the Gaucher cells, and then we have bone issues, lots of bone issues, which I'll talk about here in a little bit. So type 2 is the least common one. Generally, it's less than 5%, but some studies say it's up to 20%, so I add that in here. What's really the key thing here is that there's a neurological impairment early on, so 36 months of age. And of course, with just like type 1, there's enlarged spleen and enlarged liver. This is usually fatal, almost every single time it is. So they usually don't live past a year. On the right here, I have some pictures of some babies that have type 2. Something I really want to point out here is the B baby here has that enlarged stomach, which is a very good sign of Gaucher disease because of that enlarged spleen and enlarged liver. And then our last type is type 3. It's a little more common than type 2, but not quite as common as type 1. It has similar symptoms as type 1 with a little added effect of oculomotor neurological symptoms, so just there's neurological effect to it as well. The oculomotor is talking more about the fact that we have that spasticity in type 3. And then we can also have dementia and epilepsy as well. And then these symptoms are similar to type 1. They are sometime before age 20. They can be early, they can be later. And then on the graph here, I just show you the progression of the symptoms. And you can see type 1 has the least aggressive, type 3 is in the middle, and type 2 is the most aggressive of the symptoms. Okay, so organs that are impacted. We have skeletal, hepatic, and lymphatic, so the liver and the spleen and the bones. Skeletal issues, we have mainly what's going to happen here is that the bone cells are going to be blocked from doing their job by the Gaucher cells. And so we see in this picture up here that the porous bone tends to happen here because we have the Gaucher cells impacting those bone cells. And so we kind of get osteoporosis, so the porous bone. We get osteonecrosis, so we get the decay of our bone. We get bone crises, which are things that just really painful walking and movement, and then a lot of fractures and vertebral collapses from the fact that the bones weaken. Hepatic issues and lymphatic issues are the same. They are enlarged organs, so it's enlarged liver and enlarged spleen. So with the bone issues, we have difficulty moving and painful movements. Something that's really interesting here is that you're 26 more times more likely to develop Parkinson's disease compared to the general population. They think this is due to the fact that the Gaucher cells are impacting the nervous system. And something else that's important here is that with an enlarged spleen, we get that reduced number of red blood cells, platelets, and white blood cells. So we have a higher chance of getting sick and infections, and especially with fatigue. And then the idea that we get neurological impairment is due to the fact that we accumulate these Gaucher cells within the brain. Okay, so how can we test or diagnose this? We have bone marrow aspiration, which is less common. The way you can do this is down here on the left, you see that we have to take bone marrow from this. So that's why it's less common. It's a painful procedure. And it's hard to tell between Gaucher and pseudo-Gaucher cells. Something that is true across the board is there has to be a deficiency in the GCase activity. And we can look at the total leukocytes for that. And generally, it's going to be 10 to 15% less than the normal. So you can see down here at the bottom right, the fact that normal values of activity, and then we see that the type 1, type 2, and type 3 are just way below that. Another way we can do is genetic testing. Generally, the problem with this is they try to do it when you're when still a fetus, and these are dangerous. So we have the chorionic villus sampling, which once again is dangerous because you have to put a needle or tube into the membrane down there, and that can be very dangerous to the baby. And then at 16 weeks, we can also do it with amniotic fluid testing. Once again, using a needle can be dangerous to the baby. Blood tests, the problem here with that is there's few biomarkers. At the same time, there's actually too many at the same time. And what I mean by few biomarkers, there are few biomarkers that are actually useful. And even then, they're not 100% accurate. And so you just have so many that it's hard to tell based the severity of the disease on them. So our first type of treatment is the enzyme replacement therapy, or ERT. The goal of this is obviously, like it says in the title, to replace the missing enzyme, so the GCase, back into cells so we can get rid of that buildup of our substrate. Usually we start with around 60 units per kilogram every other week for adults and babies, or children. So down here, it's approved for type 3. Type 2 has no effect. And then type 1 is most common, but generally we don't want to start it until the patient is symptomatic. Our second type of most common treatment, and this is the second line of defense, is the substrate reduction therapy, or SRT. The goal of this one, like in the title, is to reduce the amount of substrate that's produced so it doesn't accumulate as fast. And so what we did is we try to inhibit that glucoceramide synthase And so we're inhibiting that. And then the reason we don't use this as much is not as successful. So we'd rather use ERT. The only time we use this is when ERT is not successful or you can't do it with that patient. But generally, it also shows some success, just like ERT does. Other treatments used to be bone marrow transplant. The benefit to risk ratio was way too low. There wasn't much benefit. It was very painful, and it wasn't as effective as ERT. Gene therapy has proven to not be successful, but recently they had some studies that come about showing that there could be some ways that it could be successful, but this is in mice, so we're far away kind of from anything with humans. Molecular chaperones, similar to gene therapy, has positive outcomes. And this has only been done really in Parkinson's patients, so we're still kind of waiting for clinical trials, but most people seem to be most excited about the molecular chaperones. Health professionals. So how can we have a team that's helpful with this disease? So it's been shown that Gaucher's patients have a reduced metabolism and are more overweight and more obese. And so what I think would be most helpful here would have a dietitian to help them kind of control their healthy eating and try to help monitor their weight. And with the bone crises and the painful walking, I think a PMR doctor or a physical therapist would be helpful to maintain that pain. And here on the right, we're comparing the energy expenditures of someone with Gaucher and normal healthy controls. And if we look here at the black line, you see how much lower our metabolism is than those that have our normal healthy controls. Okay, so what are some difficulties with the disease? The genotypes don't always lead to a phenotype, so we can't really tell what the phenotype is going to be based on the genotype, like I said earlier, because there's so many different mutations. There's, like I said earlier as well, there's really no gold standard for biomarkers. There's a large quantity of biomarkers that they like, but none of them are very good indicators with either disease severity or the disease itself. Other things is costly. Bone diseases can arise from bone treatments, and then therapy for the neuro symptoms. So future. So like I said earlier, gene therapy has been promising in some Parkinson's patients, so hopefully that will be something that can arise later. There's no current cures or any plans for a cure right now. And with ERT and SRT being so effective, it doesn't seem there's a whole lot of motivation to find different treatments. Here on the right is just showing the fact that it is very costly to have some of these treatments. And so what they'll do is saying like effectiveness versus the cost here. And we see that although it may be effective for treatment, it is just very costly. And here are some of my references.